So for the last part, let's go to the bioethics in family medicine. So we have the following topics, no? So bioethics in doctor-patient relationship, the PMA Code of Medical Ethics, and advanced directives. So for the doctor-patient relationship, we have the following bioethical principles. So first would be non-maleficence. So this implies that we should always remember to not do, risk, nor create any harm or injury to our patients, either through acts of commission or omission. So our role as healthcare professionals is that we must undergo continuing medical education to upgrade our skills and knowledge so that our patients will not suffer because of ignorance. So that's why we attend webinars, trainings, and conventions, no, to update us. So in palliative care settings, examples of possible violations of the principle of non-maleficence include providing unnecessary but potential harmful interventions, failing to stop treatment when the burden begins to exceed the benefit, failing to give adequate doses of medications to control pain and other distressing symptoms. Next, ethical principle would be that of beneficence. So beneficence implies that we should do what is good for the person and or society. So a manifestation of beneficence is an action in the best interest of a person. No? So we perform acts of charity, kindness, and mercy. We come to the aid of the injured, the sick, and the dying, and relieve the suffering. So in palliative care, positive acts that implies beneficence include treating pain and other symptoms effectively, providing relief and comfort for psychosocial and spiritual problems. For justice, so this is based on the principle of giving a person his or her due. So this implies that we should be fair to all and promote equity and equality of care. So this underlies the allocation and distribution of resources and the concept of the right to health care. So our role as healthcare professionals is to provide equal health care to all patients without discrimination. No? So whether the patient is very poor or whether the patient is very wealthy. No? So we provide equal health care. So in delivery of health care, so we give each patient what is due, the available care he or she needs, and information and confidentiality. Okay, so now we go to the principle of autonomy. So autonomy implies that we should respect a person's right to self-determination. So it allows individuals to have freedom and authority over decisions regarding their lives and treatment in accord with their own particular values, conscience, and religious convictions. No? So this includes the freedom to be given all relevant information and the freedom to choose among all ethical, legal, and medically available choices. So patients with decision-making capacity are free to reject without coercion or fear of retribution any form of medical therapy, including life-prolonging or life-sustaining therapy. A patient's right to refuse unwanted treatment, including nutrition and hydration, is absolute. Okay? So the principle of autonomy includes the patient's right not only to refuse a particular treatment, but also to ask that the treatment be modified based on their needs and preferences. Okay? So this is the basis for the practice of informed consent. So informed consent is the basic mandate is physicians must obtain the free and informed consent of a patient if the patient is competent to give the consent. So it is the process whereby patients, after sufficiently being informed, they make rational decisions to consent or not to a procedure, diagnosis, or treatment. No, so before doing history taking and physical exam, so we also ask the consent of our patients. No, so we have the elements of informed consent. So we have competency. So this is the ability to perform a task. No, so consider the concept of decision-making capacity. No, so a patient is presumed to have decision-making capacity unless proven otherwise. Although it can be temporarily or permanently compromised, no, by conditions like delirium, dementia, or those patients in severe pain. So if a patient lacks decision-making capacity, the designated surrogate has the authority to make decisions based on the patient's advanced directives, if there are any. However, if there are no directives, no, so we apply the patient's preferences and values. So if ever the values and preferences are unknown, so we choose a reasonable person. So we choose as a reasonable person would want in this in the patient's circumstances. No, so what we will do to the patient. So we have disclosure of information. No, so information that must be communicated by the physician to the patient before consent includes the nature and purpose of the treatment, the risk and discomforts, the benefits, and available alternatives. No, so patients usually would want to know the risk and benefits. No, so if there are some patients who present themselves as wanting to know everything, so they should be told about the risk of death, no matter how low, and they should also be told of any risk of the procedures, no matter how small the risk, and they also should be told about the alternative so they could make the decision after being sufficiently informed. Okay, so next is the comprehension or understanding. So physicians should share information and options fairly and should constantly assess how much the patient and family understand the diagnostic and treatment choices, especially those involving the risk. So lastly would be the voluntariness and freedom. So this should be again voluntary. So decisions may be influenced by persuasion but not by coercion or manipulation. No? So that's why since we are in the era of evidence-based medicine, no, so we can use this as a means to persuade our patients, no, so towards any treatment or diagnostics, no, that is ethically appropriate for the approach in our patient. Okay. So next is confidentiality. No? So permission of the patient is secured for people who will be present during the discussion and for information that will be shared for teaching purposes, since we are again in CBGH, a teaching hospital. However, sometimes it may be appropriate to breach confidentiality. So in general, patient confidentiality can be breached for three broad reasons. So we have number one, avoiding harm to others. Number two, benefiting the patient. And number three, for public health reporting. This is especially exemplified during the times of pandemic. No, katong, we inform the appropriate LGU or barangays, no, if they have positive patients na nag-reside there. So kato lang, they cordon. So it also provided a backlash because some patients do not go to the laboratories anymore to get treated or tested. So now we go to PMA Code of Medical Ethics. So we have duties to our patients, no? So the family doctors must be able to treat their patients according to their best judgment and be able to refer patients who are beyond their capacity to treat. Also, we should know our limit. The family doctor should fully inform their patients and defer to the patient's opinion in accepting or rejecting the proposed plans of management. Again, principle of autonomy. So promotion and advancement of health of patients should be prioritized over the perks of physicians and of healthcare product industries. And physicians should hold as sacred and highly confidential whatever may be discovered or learned that is pertinent to the patient even after the patient's death, except again for the promotion of justice, safety, and public health, which requires us to act otherwise. And we are also free to choose our patients. So for our duty to our colleagues, so family physicians should work together harmoniously and should be willing and graciously render service to their colleagues, their spouse, minor children, or even their parents, provided that they are aged and being supported by the colleague. Constructive criticism should be done directly and privately to the colleague involved. And in cases of emergency, when the attending physician is absent, the current physician on duty should transfer the patient to the original physician upon arrival of the latter, no? Or when the physician is out of town, so a substitute physician shall treat the patient with the same dedication and quality of care extended to his or her own patient. And the patient should be returned to the care of the primary physician as soon as possible. No, so dili kay you will get that patient as your own. No, so you return the patient. Okay? And we should also expose without fear or favor corrupt or dishonest conduct of members of the profession. Next is our duty to the community. So we cooperate with the duly constituted health authorities and the dissemination and enforcement of laws and regulations for the promotion of health, and must be able to assist the government by giving just and fair recommendations when called upon to act as expert witnesses. And lastly, should be encouraged to expose and report to the proper authorities and licensed medical practitioners, quacks, who are doing practices that cause injury to the people. So for end-of-life care, we are committed to relieve pain and suffering and to uphold their professional commitment. So our most radical duty to our patients is, again, above all, do no harm. So our cooperation in euthanasia, homicide, and suicide cannot be considered an act of genuine empathy, but of misplaced compassion or false mercy. So now we will go to advanced directives. No? So advanced directives is rooted in the ethical principle of, again, patient autonomy. So it's a legal document that allows the patient to specify the extent to which he or she would like to have life-sustaining treatments if he or she develops specific medical problems while being incompetent. So we have different types. So we have instructive directives. So this is written by a person with decision-making capacity and becomes effective when the person's capacity to make healthcare decisions is compromised. So example are the living wills and medical directives. No, so this is not synonymous to a physician's order. So the physician should honor the intent of a patient's advance directive, and after consultation with the patient or the surrogate and family, if the patient is incompetent, write appropriate orders. Okay. So we also have the proxy directives, no? So a proxy directive is wherein a person is authorized to make healthcare decisions on behalf of a patient in the event that the patient loses decision-making capacity. So example is your durable power of attorney for healthcare and designation of a healthcare surrogate. So in the absence of a proxy directive, no, so in most often than not, so the designated proxy in order of importance is the patient's spouse, then the adult children, then the parents or siblings to act as the patient's surrogate. So neither the patient's physician nor members of the palliative care team should serve as the patient's surrogate. Okay? So the proxy is invaluable when the patient wants someone other than the spouse to act as the proxy, or if there are disagreements among family members that cannot be resolved, or if ever the patient has non-existent family members or unavailable family members. So in do not resuscitate orders, this is a designation requested by the patient or the patient's proxy. So it is a declaration to forego cardiopulmonary resuscitation in the event of a cardiopulmonary arrest. So in the event of an arrest, no? So thus, except during an actual arrest, a DNR order provides no directive on diagnostic and treatment issues experienced before the actual arrest. So the degree of diagnostic workup and treatment desired by the patient or proxy should not be inferred from the DNR order. DNR in and of itself is not sufficient to communicate healthcare plans. In addition to a DNR order, physicians should properly document the patient's current healthcare directives, preferences, and care plans. So this, we don't have DNR form in CVGH. So this is our A and B form. No? So we let the patient sign if ever he or she can, but most of the times we let the significant other sign, no, after they have a family meeting, whether they want to let the patient have a natural death. No, so A and B stands for allow natural death. So this is the template from the hospice and palliative care module by the PAFP. No, so aside from the actual CPR, usually for advanced directives, no, so it includes so here it includes your medical treatments or interventions, your life prolonging interventions, no, so ET tube, ventilator, medication, CPR, and aside from that, advanced directives also include dialysis and blood transfusions, no, so it is not only limited to those advanced any ACLS na interventions. So this also includes palliative care, no, and it should be signed by the patient and then by the attending physician and a witness. So these are the references, and thank you.